Great. Well, wonderful to be here and exciting to see some friends from Texas that came up, as well as friends from all across the U.S. on this very interesting and unique meeting. I'll focus on women in MPNs. I think is long overdue. I think this is part of our continuing realization of all the things that we as individuals bring to the table when we have an illness. We're never an illness. We're never defined by just being an illness. We're individuals, whether that be gender, whether that be culture, whether that be age, whether it be our level of fitness, our family history, our beliefs, our spirituality. All of these things really come into play as we focus on these things. So Anne asked me to give this kind of historical retrospective. So one, I took that aback, because usually it's a sign that you're getting old, that you start getting these kind of history of MPNs. And I did want to remind her that Dick Silver still has 40 years on me. So at least there's a pretty broad range between kind of Robin and Dick Silver. There's a broad range of us kind of in the MPN world. But so here are my disclosures. I pretty much engage with everyone in one form or the other. So as we do a little bit of a history, and I'm going to give it in a way that hopefully is helpful, because one could get really lost in the weeds with this sort of thing. But first, the natural question is, so how did I myself get kind of involved with MPNs? So first, a bit about myself. I'm a Chicagoan. There we go. So go Bears, except those that saw the miserable game last night. Myself, then I was an Illini, a wonderful University of Illinois. Originally was going to be a nuclear engineer, but a little thing called Chernobyl happened, and ended up going into medicine. But my link back to the blood diseases perhaps goes back to when I was a kid. This is, as you can tell from the very stylish uniform of St. Peter's. But I had an interest in the blood, as well as leukemia really very early on in my career, if you would. Funny, my mother actually kept this paper. I haven't had the gall to put it on my CV, in that it was not peer-reviewed, However, sadly, many of the drugs we still use were in this report, written in pencil, including hydroxyurea. So that is a bit ironic. As I evolved along the way, I moved up to the Mayo Clinic in Rochester. It's a sunny spot, it's really lovely year-round, and up there, an amazing medical place on so many levels. And again, life is a bit of both opportunities and exposures. Now, the Mayo Clinic had really a long history of being an institution with a deep concern for patients with MPNs, going way back into the 30s, 40s, and 50s, including these individuals that you probably have not heard too much about, and particularly Murray Silverstein, who was truly larger than life himself. He was this now passed, but very, very famous, very funny hematologist that focused on MPNs. And he got with him a very energetic fellow that you have heard of by the name of Ayalu Teferi, who, when he was a fellow, recruited me then in medical school with the discussion, Ruben, have you heard about myelofibrosis? So he wove me in, and I had a chance to meet patients with MPNs, participate with research, really saw the tremendous unmet need, met many wonderful individuals, and that was a bit of my start with MPNs. Now then I moved on to the Mayo Clinic in Arizona. I was paroled for good behavior to better weather. And then most recently I've had the great honor of leading the wonderful men and women, nurses, physicians, and scientists of the Mays Cancer Center in San Antonio, Texas. Now, moving to Texas itself is really its own unique thing. Texas is a fantastic state, but it truly is its own country. And you're probably only there about 5 minutes before you were reminded that Texas was its own country. It's a little big. we measure things sometimes in the hundreds of miles. This is by us the very Texas-sized Buc-ee's. And if you've not been to one of these, nothing really epitomizes Texas perhaps better than Buc-ee's. This is the single largest convenience store gas station on planet Earth, out there by New Braunfels, with 144 gas pumps, and the central convenience area is the size of a Walmart. Now, Texas, if you drop it on Europe, this is my favorite slide I love to share with my European colleagues, is the size of Europe, pretty much, if you were to drop it on there, where you can be in one part of the state and have El Paso 850 miles one way and Beaumont 23 the other. Now, Texans also can be a little strong-willed, as one can find, including sometimes very distinct political leanings. So enough about me. Let's talk about MPNs. Now, MPNs, as opposed to a detailed part, we're going to do this a bit more thematically. So first, as I think about MPNs, there's really MPNs pre-2005, before we really started to understand the biology and the molecular mechanisms and some of the parts that Dr. Mullally so eloquently discussed. And they're really a post-2005. Now, pre-2005, we clearly knew that the MPNs were a series of diseases, that there was elevation in the blood counts. And our body, our blood is made in the bone marrow. Each of our cells have very specific roles, and the body controls the number of cells we make very specifically. And too much or too few of any cell has major implications. So just like any sort of thermostat or regulated system, the body controls the number of cells very, very tightly. Now, the real origin of even people thinking about MPNs was the noticing of the elevation in the counts and then how people were affected. And why I loop in the pre-2005 is that pre-2005, the major issue was really trying to distinguish between an elevation in the counts for some other reason or a reaction versus really an illness, a primary illness. Indeed, there's even individuals who are born with too many blood cells. Just having an elevation in the blood cells is not the definition of a disease. So there's multiple reasons we can have too many red blood cells, living at high altitude or not having enough oxygen, or even heart-lung conditions. Perhaps the Cleveland Clinic meeting going on the other floor with the valvular diseases. Again, some of them may have too many red blood cells. There are multiple things that can lead to an elevation in the platelets. Somebody had their spleen removed because they had a motorcycle accident, that might increase platelets. If they're iron deficient, that might increase platelets. There are other causes of fibrosis or scarring in the marrow. Now, these are probably less common than the secondary causes of erythrocytosis or thrombocytosis. But pre-2005, we spent a lot of energy just trying to see, did somebody actually have an illness, or was it one of these other things really leading to the elevation in the counts? Now, the first person that really coined this term of, at that point, myeloproliferative disorders was William Damashek, who was a very famous hematologist, and this was in the 50s. And at that point, he lumped together, he speculated that a series of different diseases, agnogenic myeloid metaplasia is now what we call myelofibrosis, polycythemia vera, CML, which at that point was called CGL, were things that he speculated were linked together. Now, this is a big component. Pre-2005, the diseases had been called myeloproliferative disorders, meaning they didn't necessarily know that they were related cells. They didn't necessarily think of it as a chronic leukemia. And it was not clear, was this like an inflammatory disease like lupus or rheumatoid arthritis? Or really, was it a clonal neoplasm? So that was a major evolution in our thinking. Now, in terms of therapy, I'll really break it down into three main kind of concepts. First, our therapy largely had focused on trying to decrease the risk of blood clots and bleeding in ET and PV through either controlling hematocrit through phlebotomy, maybe using aspirin, we'll get into that in a moment, selective use of medicine to lower the counts. The treatment of myelofibrosis was pretty inadequate and largely dealt with trying to help certain things. The spleen was big, maybe we'd do surgery, maybe we'd do radiation, maybe we'd give chemotherapy. If there was anemia, it was a struggle. It still is a struggle. For the symptoms, there really was very little. And indeed, even the concept of symptoms, as Ruben very nicely discussed, was very limited in understanding. And finally, stem cell transplant at first didn't even thought that it could be applied to MPNs, and then was tested in myelofibrosis and was successful, at least for very specific types of individuals. Now, some of the key underlying things that I'd highlight in that history is first the issue of aspirin. So interestingly, back in the 60s, there was a concern actually that aspirin was unsafe in patients with MPNs. They had done a study. People had 4 adult aspirin, so that's like 1,200 plus milligrams of aspirin. And with that study, people had, not surprisingly, a higher risk of stomach ulcers. So they thought, well, it might be helpful, but it's not safe. So for many years, no one used aspirin with patients with MPNs. So our colleagues in Italy wisely thought, well, maybe it's just an issue of dose. In other diseases, and this is a theme, we are not in isolation. As a medical community, we learn from the heart doctors. We learn from people studying things in parallel. We learned that a baby aspirin, or 81 milligrams of aspirin, was safe and helpful for preventing stroke, preventing heart attack, etc. And similarly, proved to be helpful in patients with PV. Now, the studies have been primarily in PV. We largely extend that now to the other MPNs, but our true trial data is still specific for PV. What about hydroxyurea? Hydroxyurea, an old drug, it was never really developed for MPNs. Indeed, it's approved for several things now, none of which it's actually used for. It's approved in CML, it's approved in head and neck cancers, it's approved in ovarian cancers. We don't really rarely use it in any of those circumstances. But in MPNs, it has been used. It's such an old drug that it's somewhat of a grandfather type drug as it relates to using it in MPNs. The studies that supported its use were really trying to decrease the burden of thrombosis or blood clots in patients with ET. So I like to say hydroxyurea has really good data in ET. It has okay data in PV, and it's not very helpful overall in MF. Now, anagrelide was developed, there's that Murray Silverstein in the corner, with studies done at Mayo Clinic. Now, this is a different era, so it was not compared against anything. It was a drug that could lower the platelets. It's fallen somewhat out of favor secondary to side effects and other things, but is one of our platelet-lowering drugs. Now, there was a study done, a very important study, pre the discovery of JAK2, that compared Hydrea and anagrelide, the PT1 study. And I highlight this because this was a very important study in a variety of ways. One, it was one of the biggest studies done in MPNs up to that point in time. And two, it took 2 of the main therapies and really compared them. And it was a study really designed to show that anagrelide was going to be better. And as often is the case, regardless of what you think going into a study, the outcomes aren't necessarily always what you expect. And what it demonstrated is that overall the hydroxyurea was probably better than the anagrelide. It probably was better tolerated. It probably was a little safer. It was probably a little more effective. It didn't mean we shouldn't never consider anagrelide, but it did demonstrate, much to the chagrin of the people who make anagrelide, who paid for the study, that hydroxyurea was better. Now, another thing I would highlight is not a medicine-related piece, but is really things like this. The MPN community has really been a leader, I must have a time thing there, really been a leader in the development of patient meetings. And Joyce Niblack, who's there in the, on the upper right panel there, deserves a lot of credit for that, as well as many others. So long before there were all sorts of patient meetings for all sorts of different reasons, she was a patient, she was an advocate, she was an attorney, and she was a force of nature. And she had the idea of trying to bring together physicians, scientists, and patients to interact and talk. And at that point, that was heresy. You know, physicians never would agree to be in a venue like this where people would be tossing them questions from the back of the room. I mean, people would rather, you know, run out screaming than have to face, you know, something like that. So it was a very, very interesting and provocative thing, and really had tremendous impact that really ended up leading to many other areas really copying this for many reasons. One, it creates a sense of community. It's very helpful, more general education. It allows people to get in much greater depth than they do in the kind of context of a physician visit. But it's also been the platform for really having that community be engaged in a variety of research efforts that were impactful. And indeed, as we end up talking about the JAK2 mutation, a patient meeting actually helped with that. So what about post-2005? Well, there I'm going to focus on a few key themes. The first has really been we have learned much more about the biology of MPNs than we ever clearly knew before. And clearly Dr. Mullally's talk was a prime example of that, where she and her colleagues take a very deep dive in very specific mechanisms of that biology. And even that biology as it relates to calreticulin may end up being very distinct than other pathways that can be involved. Now that JAK2 mutation was discovered back in 2005. Many labs found this around the same time, although it's credited that the first discovery of this really is with the group in France. Another one of these it was very interesting because all 4 labs ended up finding the same conclusion, but they all went about it in 4 different ways. And actually that was incredibly important because it showed us right from the beginning that this was very, very real. Because it was 4 groups coming at the same question 4 different ways, and they all came up with the same answer. So there was no question this was a very, very big deal. And why that was important, simply put, all of these different mutations that you end up hearing basically really impact on how our body is regulating the number of cells in the blood that it is making, with things either increasing or decreasing that, with many variations on how that is affected. Now in this nice slide that Alison Moliterno shared with me, again, we've seen kind of that evolution of more and more of the genetic changes that are being discovered and how they interact. Now there are many more layers to that. I like to share with my patients, it's a bit like a jigsaw puzzle. And when the jigsaw puzzle is complete, we'll have a full picture of why do people develop an MPN, why do they progress, why do some people clot versus some people bleed, why do some people have symptoms and some not, why do some people end up having a disease that progresses to become life-threatening and others have it with very little consequence. But we only have some of the pieces on the board with that jigsaw puzzle, and that really is where the research comes into play. And indeed, we have learned that these spectrum of mutations affect the majority of individuals, have some mutation or another, or combinations of them. We've increasingly learned about longer and longer lists of potential mutations and different ways that they are expressed. Indeed, even amongst the mutations, there end up being more and more subtleties. The other day, I was just emailing Dr. Ann Mullally about a very specific rare variant of a mutation in one of these mutations called MPL, that again, perhaps has a genetic familial link from people of Middle Eastern descent. So the more we learn, the more narrow some of this information becomes, the more subtle it becomes. And there's other layers that we're just finding out in terms of how things are expressed. What % of the cells in the bloodstream are actually affected by one particular mutation or another may be relevant. Now, Robin had showed this slide earlier as well. And again, over this last 14 years, we've learned quite a bit more, but not everything yet, in terms of why people develop, progress, or develop vascular symptoms. Now, the next theme, just at a high level, is what Ruben discussed, which is really MPN and symptoms. But perhaps a little bit more broadly, thinking about MPNs and disease burden. Indeed, the burden of having an MPN is quite variable. You know, even as I think around this room, some of you might have multiple ways the disease has affected you. Others have not had necessarily any of these sorts of things. Perhaps you're concerned about the future, all of these different sorts of things, but the burden is quite different. And that the burden is not necessarily just linked with what subtype of MPN you have. Indeed, I could take patients with ET or PV or MF, and with any one of those diagnoses, I can point to a patient who feels pretty well and things are pretty well controlled, people who don't feel very well, or any mixture in between. Now, the other way we have learned about disease burden is about the concept of risk. You'll see that there's a tremendous amount of things that are constantly being discussed about the issue of risk. And one thing about risk with MPN, it's always very important to think, well, what exactly are the doctors talking about? Is there a risk of having a blood clot or bleeding? Is there a risk of progression? Or is there a risk of this disease being the reason that I pass away? And the risk of each of those things really might be distinct. Indeed, some things that increase your risk of having a blood clot don't necessarily mean that the disease is more likely to be life-threatening, or vice versa. Somebody might have features that suggest the disease might be more likely to progress to acute leukemia, but that does not necessarily mean that they have a higher risk of blood clots or bleeding. So there's differences in how we assess the issue of risk. And we've learned much more about that over this past 14 years of time. This is an example in myelofibrosis. What used to be simple now has become incredibly complex, where we look at clinical features, we look at some of these genetic changes, we look at how the disease is affecting you in terms of estimating risk. Now, the other thing that's not in here, and in part because it's difficult to do in studies where we look at old medical charts, but really is the health of the individual. A disease does not exist in a vacuum. You know, so the fitness of an individual, their physical activity, their family history of cardiovascular disease, what they're eating, their stress levels, all of these sorts of things matter, because a disease does not live in a vacuum. It lives in you. And everything else you bring to the table is important. So the healthier the rest of you is overall, the better off you are almost regardless. Likewise, if other things are really compromising your health, then an MPN can really aggravate that situation. Now, we've learned a lot about symptoms. Now, this was not always something to be taken for granted, that we knew this. Again, Joyce Niblack was really instrumental with this. Early on, for many years, the symptoms associated with MPNs were largely discounted. They were things really not recognized. Physicians really were not focused on this piece. So Joyce challenged me probably about 20 years ago to try to prove that these things mattered. So I'm like, great. I'm like, Joyce, why don't we partner together? You have this online community. The internet really had just started being a thing. And let's do some surveys. So we did a first survey with almost 1,500 patients. Certainly patients felt that they had symptoms. So we had data. It was well done in terms of the methods for doing a survey study. Submitted it to get published. And the first reviewer said, well, I have 2 MPN patients in my clinic. None of them have symptoms, so I think this is bogus. Another reviewer thought MPN patients were lying on the surveys and didn't think the results were valid. The third wanted biopsy confirmation of all 1,500 diagnoses before publishing it. So we ended up getting it published, but that just showed you a little bit of the headwinds we faced, as it related to that piece. Now, we've come a long way since then. we've developed the tools with a tremendous effort from Ruben and the whole team, and now have data really in thousands of patients around the world as it relates to symptoms. And we've learned quite a bit. One, symptoms are present in patients around the world. Two, the ranking of the symptoms by disease actually seem very, very similar, irrespective of geography. So if we compare people in Uruguay to Japan to Australia to North Africa to Europe to Texas to Boston, the ranking is pretty similar. Now, interestingly, there are cultural impact in terms of severity. And that in itself is its own sociologic PhD just waiting to happen. We've developed this 10-item scale. It's become highly validated. This is an example of it in English and Arabic, and in Arabic going the other way, of course. We've looked at symptoms in a whole variety of ways. And again, this is a heat map approach where each line are individual patients from bottom to top. And this is data in about 2,000 patients. And the wonderful talk by Dr. Corey that you heard earlier, you see that line across the bottom in red as it relates to intimacy and sexuality, and you see really what a common theme that is. Again, I think a manifestation of many things, and that was such an elegant discussion of that earlier today. Now, the MPN community has become a leader. The FDA now views the efforts that have been done in terms of quantifying symptoms and having that be a part of drug testing as a model for other diseases. So now every trial pretty much that exists for patients with MPNs is using a similar methodology, and actually that's been used as an example for brain cancers, for pancreatic cancer, for even other diseases. Other things we've learned that the burden does not solely focus on symptoms. It also impacts clearly anxiety and distress. Indeed, one of the things that we've identified is that individuals with MPNs have, and in many cases appropriately, significant anxiety or concerns regarding the risk of progression. And that sometimes this is not in alignment with where their physicians necessarily think the burden lies. So we've identified a variety of things as it related to prioritization, communication between physicians and patients, and been active in speaking on these issues. So conclude this piece, our broader group of many of us, including Dr. Fleischman, Ruben, and many others, are part of an MPN quality of life study group where we kind of ask the questions, in parallel with developing the best therapies, how do we try to look at additional things individuals can do to try to feel better, whether that be related to yoga, physical activity, meditation, nutrition, dietary interventions, or cognitive interventions. And I could say that the MPNs are, without question, the leaders in certainly related to the heme malignancies, and really in the entire cancer world, other than in breast cancer, there probably is not as extensive a portfolio of non-pharmacologic studies being done other than in breast cancer. So we are additionally focusing now on this biology of the MPN symptoms, how they relate to inflammation, as you've been hearing about, how they relate to distress. The next theme is really developing MPN-specific therapy. So if there's really been an evolution, is we've evolved from therapies that we largely had to beg, borrow, or steal from another reason to use in MPNs. Now, prior to the JAK inhibitors, the therapies that we had used, largely we had used for something else. They were developed for other things. Hydroxyurea was not developed for MPNs. Interferon has been tried in every disease known to man, from male pattern baldness, you know, I mean, the list of things interferon has been tried is enormous. Now, it's found a home in very specific dosing and formulations in MPNs, but wow, that was really not the case. Indeed, it has many things that it was used in very high doses that give people a lot of almost PTSD even thinking about it. So many of the physicians that people run across that really are quite reluctant about interferon, they have very bad experiences, but for very different doses in very different diseases. But the first drug where a company actually said, we want to develop a drug to get approved in MPNs were the JAK inhibitors. And the first of them to be approved was ruxolitinib. Now approved because of, now for many years, since almost 10 years, in terms of improvement in symptoms and improvement in the size of the spleen. And we saw that ruxolitinib probably helps people who need it in myelofibrosis live longer with the disease. Now, it doesn't cure the disease, so our work is not done. Now, the discovery of the JAK2 mutation led to really an entire kind of gold rush, if you would, of drugs being developed that were JAK inhibitors to try to be active against the disease. Up to this point, ruxolitinib had been the sole approved drug. Now I need to update the slide further. Fedratinib was just approved in patients with myelofibrosis a little over a week ago, and has some additional testing that is ongoing. There's others that are close to becoming approved, pacritinib and momelotinib. But there are multiple others that were tested that now have gone by the wayside. Now, I'll just show you this as a high level to show you that there's tremendous effort going on with specific therapies for MPNs. There are the JAK inhibitors that I mentioned, but it's not limited to that. There are other drugs looking at other pathways. Now, are any of these ready yet to say that you need to be on them? Not yet. That's why clinical trials exist. We think they might be helpful, but we need to prove that they're helpful, and we need to prove that they're better than what we're giving you otherwise. And that depends on your exact situation, your exact disease, how the disease is affecting you, to show whether that's the case. A drug might be helpful in ET, but not be appropriate for MF. A drug might be helpful in MF, but maybe only in a subset of MF. So many different studies ongoing, but all very specifically geared to very specific individuals in specific circumstances. Now, the final thing I'll highlight is trying to bring some uniformity to our treatments, treatment guidelines. So what is a guideline? Well, again, up through many years, everyone in the US pretty much treated MPNs however they wanted, you know, or based on the most recent talk they went to, or what they learned when they were in training 20 years ago. Or if they go to a meeting, the person that shouts the loudest about their views on how one is treated, that's how people end up getting treated. Well, we thought that that was really a gap. Unfortunately, there have been US-based guidelines that have developed for many diseases, including many cancers. Now, the group that's organized this is the National Comprehensive Cancer Network. This is almost a Mad Men sort of photo. This is not the actual NCCN panel. But a guideline, what is a guideline? Well, a guideline you could think is the guardrails. What is this science of what are the treatments? So let me give an example. For polycythemia vera, the guideline is that the initial treatment as it relates to a medicine to lower the blood counts is hydroxyurea or interferon. Both of them are reasonable. If I wanted to use a completely different drug because I thought I was being creative, let's say I wanted to use adriamycin that we use for breast cancer. No, we're going to use it for PV. That is not, there's no science behind it. I would be off base in doing it. I would be culpable for really malpractice for giving a medicine that I have no justification to give. So what is in that guardrail? Now, where your physician comes in is how do you apply that to the individual? So are you on Hydroxyurea or interferon? That is the art of medicine. And that is, again, your physician's expertise, your input into that process, etc. The guardrails are the science of medicine. What are the options? But which option, how it's applied, how is it dosed, how is it adjusted, what to expect, how long to expect for it to respond. That is the art of medicine. And with these, we've created these heinously complicated algorithms for your physicians to really try to have standardization. But it's important because they can take these standards and help and adjust your therapy or decide which therapy is used. They're helpful for people that benefit from interferon now being in the guidelines. Although not FDA approved, it is in the guidelines and frequently can be the case for reimbursement. So what does the future hold? Well, the good news is that everything that will impact MPN patients is not limited to just the scientists in this room or even the scientists working on MPNs. Because everything that is being learned in parallel medicine has relevance. People are studying the science of aging, and that may have implications for the process of MPNs. People are studying inflammation and how that is dealt with. People are studying many other things and many other cancers and blood diseases that may impact patients with MPNs. But a couple of things I'd highlight. First is there's a revolution in utilizing the immune system for better treating cancers. It's impacted many cancers. It's not impacted MPNs yet. It's been tested with mixed results, but we're only at the beginning of that journey. That may include drugs, that may include immune-based therapies using T cells, such as what we call CAR T. That may include vaccines. Calreticulin may well be amenable to vaccines. Now, which vaccine does it make sense? What would be the expectations? All complex things to answer. There may be the advent of gene editing. There's a genetic change. Can we fix that genetic change? The very first of those studies is now ongoing in non-cancer things. I believe in sickle cell in Tennessee is kind of at the forefront of that. A lot of things, which gene, how many genes do you have to fix? If you fix it, does it stay? If you fix a gene, does it not injure any other genes? So very complex, but may end up being very, very impactful. Are there other things that are come down the pike? Undoubtedly. We continue to learn more and more. So the advances from MPNs might come from within the MPN community, but they may well come from application of things that we learn outside of it as well. So I'll highlight again in one of these sort of history studies. I've truly found that it's been incredibly rewarding to be a part of the MPN community, both having some of the most wonderful and inspired colleagues an individual can have a chance to work with, tremendously caring, compassionate, and insightful patients, tremendous community. So our efforts have focused on the biology of MPNs, trying to develop better treatments for MPNs, trying to advance the quality of MPN cancer care, better understanding the burden MPN patients face, trying to advance non-pharmacologic options, and then now trying to understand better the biology of disease burden. Indeed, each of you are on a race, and the race has no finish line. The race from illness to wellness. Wellness is not the absence of disease. People can have the absence of a demonstrable clone of disease, but that is not necessarily wellness. People might have an active disease but achieve wellness. Now, in the past, we were limited to thinking that we only achieve wellness through medicine, radiation, and surgery. And the reality is that this is not the case. Indeed, everything else that Anne and others have supplemented today's discussion with are relevant. Exercise, spirituality, family, nutrition. All of these things are important. Indeed, all of these things are that make life worth living. You know, as we work against diseases like this, it's not that we're really trying to focus on death. What we're trying to focus on is life. And indeed, all those things that make life worth living. So I very much would like to compliment my group. I work with really a very inspired and energetic group of individuals across multiple institutions that form the MPN Quality of Life Study Group from Arizona State, from Irvine with Angela and her group, a group in Texas, my wonderful friends and colleagues from Mayo Clinic that remain a very active part of all of these things, and colleagues at U of A. And with that, thank you.